I want to start by wishing everybody a very happy new year. It's a wish for health, hope, and happiness for everybody with the new year. And traditionally, if you start a new year, you recap the last one, which has, of course, been an unprecedented crisis. But like all crises, it's been failures and it's been successes. It's been greatness and it's been less great. The failures and disappointments are real. We've been inundated for the last 4 months with COVID patients here in Wisconsin. It is getting better, but it's been very hard. I mean, we've worked literally 6 weeks on a 20-year-old who had multiple strokes, I'm sure related. We lost other equally young people to strokes, which I'm sure related to COVID. And this has been very difficult for everyone. But the advantages are many. I mean, this is a unique year. Probably one person told me it was the year with the least hugs, kisses, or handshakes in history. And yet so many good things came out of it. I mean, what was the things that you want to remember? Well, I choose to remember the great things that came out of 2020. And that includes the nurses, the staff, the cleaning crews, the OR, the ICU, the ER technicians, the families. I mean, this is unbelievable talent and dedication under difficult circumstances. And that's everybody. That includes the people at home who were kind enough to isolate and not spread the disease. That's been great. It's been greatness in the scientists. I mean, even though they had a very difficult year as far as being demeaned, it was the scientists that came together when a world record brought out multiple vaccines, far beyond anything ever seen before. It was the scientists that remade everything about medicine to virtual medicine, the ability to care for people virtually, to teach, and very importantly, to bring families together at a time when we had to distance, we could not travel. And that's great. Residency interviews are going on virtually. That's pretty scary. Job interviews, the same. CME, which is very good and will probably continue. All of this is both good and bad. But we're marked by the fact that this has been a challenge, and we've overcome far greater challenges as a people over time. We have. Whether it was war or whether it was pandemics or whether it was economic ruin, these things happen and they make us better, and we are much better. So we've learned important things. We've learned about simplifying. We emphasize our profession, which is a wonderful service to mankind. I mean, we're the neurosurgery department at the University of Wisconsin. I'm very proud of that. I'm proud of the fact that that is a team of people and we do so much good for so many. I'm proud of the fact that we learn to simplify and to identify the importance of family and of the everyday life. We will never, ever take an ordinary day for granted ever again. And that's a lesson. So where are we now and where are we going? Well, we are in the middle of this pandemic. There's no question about it. It's going to require renewed efforts if we're going to get through this. And this pandemic is really severe. Worldwide, millions upon millions affected. The United States, 350,000 dead. This is about 20 to 25% of the world's total from a country which is really a much smaller percentage. So while 85 million are affected worldwide, we have 20 million here. That's amazing. And that's difficult. And that's because we did not follow the rules about distancing and masking. That's really the answer. Now, there is truth that we test more and we find more than you would in Nigeria or Congo. But if you just look as the epidemiologists look at the total number of increased deaths last year in the United States, that was 500,000. So the true total of COVID is probably in its isolation and its lack of medications and its diseases which occur after the respiratory, which cause the strokes, which cause the heart attacks, which cause the renal failure. That's probably far greater than the 350,000 we know about. So what's happening? Well, what's happening really worldwide is that we are seeing a massive increase in the United States in COVID directly related to Thanksgiving and the travel that took place. That is what has happened all throughout December. So we can expect it again from the Christmas travel. That's just the way nature is. But we do have some lights that are important at the end of this tunnel. Here in Wisconsin, we're seeing that our present surge, the last 4 months, has many of these surges decreasing. We have about 70% of the patients in the hospital that we did a month ago with COVID, which means a tremendously less strain on our nurses, on our ability to provide emergent care for everyone else. And it's really just the nature of this virus. It's not like we're doing something that much better than we did a couple months ago, but just by persisting about the first three, mask, isolate, and wash hands, we are getting past this present surge. It has shown a resilience which is uncommon in viruses. Many viruses mutate, as you know, this one, and we'll talk about that, and they become less able to infect. This one appears to maintain that, although thankfully it's not becoming more fatal, but it is more infectious. The big news, however, is that it's no longer three things to do, it's four. And the fourth one is the vaccinations. And I think they're very important. I know there's controversy, and know there's uncertainty, and I know there's fear, but the way to approach that is with information. Let's just talk about vaccines. First of all, there are more than 30 being developed worldwide, and that's good. Because first of all, if a virus mutates and if it becomes resistant to one vaccine, it won't to all of the others. Second, we didn't know if we could make a vaccine this quickly. So we threw a lot of money, and other countries did as well, at companies to say, put your scientists on this. We'll even buy the vaccine beforehand. You make it, if it works, then we test it, you ship it, and we'll give it. And that's what's been happening. Now, to understand the vaccines, understand that they all work by turning your immune system against the virus. That means you take your immune system and you show it an antigen, usually a protein from that virus, and you prep it for that. That's what a vaccination is. There are basically several ways to do that. One is to give an attenuated form of the virus. You somehow have weakened it so it doesn't make you that sick. Two is to give you something similar. Let's say a different virus that you have labeled with that antigen from the killer virus. So your body sees that minor infection, develops an antibody to it, but recognizes that additional antigen whenever it sees it, when you get infected by the killer virus, and wipes it out. And the final one, the newest one, those others are more standard. The newest one was you give the blueprint for a antigen specific to that virus, and you inject that. Your cells make that protein, which of course is just maybe the wall or the spike protein. And whenever you see that spike protein, your antibodies are aware of it. Because there are these different systems, they each have to be tested. They have to be tested, do they work? They have to be tested, are they safe? And quite frankly, we're in the middle of that. Some haven't been tested to prove they're efficacious. Some haven't been proved on their safety. The two that are approved in the United States are the ones which do not inject a virus, but rather just the blueprint for the one protein, which cannot harm you. However, you must test to see if you develop a response to that, which they do. These are the Pfizer and the Moderna. And you must see if it's safe. That is the reaction safe? And that's why, how much of this antigen do you give? And that's why the dosing, do I give one dose or two? Do I have you build a big immune response all at once? Well, that might be dangerous. Maybe if we build it twice, slowly will be more efficacious. So you're beginning to see the logic of one dose or two and that sort of thing that's going on. And that's what's been going on right now. So the United States has approved the first two. The first two are the unique new ones, the ones that just give the messenger RNA. There's a safety to that, but it's expensive and it's hard to make, but easier to make, faster. The other ones, the older techniques, are coming along behind them and will and are in other parts of the world being approved. Whether our safety and efficacy tests will be met in those remains to be seen. However, I suspect that at least two more will be approved shortly. So where are we and why are we slow? Why wasn't it solved immediately? Well, it takes a while to make 300 million doses of a vaccine. And so the government of the United States actually bought 600 million doses, many of which not made yet, some of which are for vaccines that haven't been approved. But they bought 3 to 4 million doses of the two that have been approved. Now those companies have to make them and ship them. So they've shipped about 13 million so far. Okay, then you have to organize your troops, talk the teams into the fact that they should be inoculated, give the inoculations, and in both of these cases, give it twice. That takes organization. The organization hasn't been perfect, but it hasn't been imperfect either. We had hoped to inoculate 20 million people by the end of last year. We did not come close, somewhere between 2 and 4 million. We shipped 13 million doses. They have not all been given yet. So we can improve with just will and efficiency, both the manufacture and the shipping and the giving of these doses. And we will. We definitely will. We just simply need us to want to do that, and it'll happen. It'll happen more this week. Let's look at the very specific numbers here. At UW, as in throughout the United States, the decision was the first vaccinations would go to the healthcare workers who are in touch with COVID patients or potential COVID patients. So this direct patient contact at UW means 13,000 employees. We have thus far inoculated 8,000 of them. Less than 10% have declined to be inoculated for whatever reason that they might feel proper. And that's their right, at least at this time in this country. We all have stick with needing the second dose, and we are actually beginning 3 weeks in to inoculate people for their second dose. Now that means that we have held back enough dosing for everybody to get two, feeling that the tests were done on 2 doses for efficacy. It would be unwise to give half that and see what happens. That's important because in England, they're doing exactly that. They have done the calculus and said, well, 1 dose gives about 40% efficacy. 2 doses gives about 95% efficacy. Let's just give twice as many people 1 dose, and maybe as a population we'll be better off. Well, that doesn't make much sense to me because we haven't really studied if that will work or last, that 1 dose. And we know that we will have people who think they're safe because they're inoculated, and they are not. As a matter of fact, the majority would not be. But that is the logic the government in England is taking place. It's being debated here, and I myself feel that would be unwise, as many scientists do. So we are continuing to give the 2 doses as it was tested. Some vaccines are designed for 1 dose or tested to show efficacy at 1 dose. It's very important, however, I believe, that we do get other vaccines approved, because making these hundreds of millions of doses is not as easy as one might hope. And having multiple companies making multiple vaccines with equal efficacy would be ideal. It would also help against a potential mutation within the agent. So who goes next? If we get to health workers, and we should this month, who should go next? Well, The United States has said institutionalized people, such as nursing homes or facilities for people with special needs. And that's very reasonable. They have looked at the less difficult to transport vaccination and the drug companies, that is to say, drug stores such as Walgreens, to be the people who would provide those inoculations to those nursing homes. And that is just beginning to start now and will take a good month. If we're really able to get the system going, we get to the general public, and I predict the general public in a month or 6 weeks from now will start be getting shots according to who's at highest risk first, and that will have to do with their medical comorbidities and age. Age being by far the most important factor for survival or lack of survival from this disease. Although everyone is at risk of these complications of strokes, vasculitis, heart attacks, but it's smaller percentages in the younger people. So the logic of 1 dose versus 2 doses brings up this whole question of mutations. All viruses mutate. As a matter of fact, that's what the epidemiologists follow to be able to say, aha, you got the COVID strain that came through Milan. You got the one that came through Wuhan. Yours spread from Miami to Houston to California. And that's been helpful because these are simply birthmarks on the virus in its genome. They didn't affect its efficacy or its infectiousness. However, the most recent mutation, which has caused concern, seen first in England and now will shortly be seen worldwide, seems to make it more infectious, but not more deadly. It is unknown, but hopefully will be known within the week if it changes the response to any of the vaccines. It's very unlikely that it would change the response to all vaccines, but it is possible, although quite unlikely, that a mutation would disguise that antigen that was chosen by the vaccines. The only way to tell that is to test for it, and that's what they're doing now. So that is not a reason not to get vaccinated, but it's very important to make sure the vaccine that we get is effective against the mutation, which is most common. Now, mutations in viruses and vaccines have always had this relationship. Those, like coronavirus, that don't mutate as much as some others are a better setup for a vaccine to work. Those that mutate too much, like common cold or some of the flu viruses, they're very hard to get the vaccine right each year. Smallpox didn't, and we could wipe it out. We hope coronavirus's mutations turn out to be only birthmarks so we can identify it and not effectively change its response to treatments. So this is the logic of mutations and the logic of booster doses. How much antigen can I give at one time without the response to the shot making you too sick? And that's why it's spread out in 2 doses commonly, as it is for the new shingles shot. So what we're trying to do is find a fourfold approach now. Vaccinate as many as possible to identify enough people protected from the vaccine that it will die out because it can't find new hosts. Isolate until it does die out. Mask until it does die out. Wash hands. We all hope that we get to that period of time when we're back to hugs and kisses and handshakes. It will come. I don't know exactly when. The vaccinations of people who are not in healthcare will come. I predict it will come in March, but it may be faster or slower. I predict it'll come in March because I think we will mobilize the will to make the vaccine, distribute it, and give it to those that wish it. And I believe that we will have learned a lot from this. We will have learned about how to be doctors, nurses, professionals like all of you. And so I'm going to end this because on a quote, as I like to, because I want to understand that we're addressing health disparities, this distribution of vaccines, this distribution of illness, and we're looking at worldwide. We're developing multiple vaccines because we need ones that we can store without deep freezers so we can get it to the Congo, which I was talking to today. We need to take care of everyone because my quote today is from Hippocrates, generally the founder of all of medicine, who said he wished to advocate for the patient in need and strive for justice for those I care for. That's what we stand for. That's what you stand for. That's why I'm so proud of you. Thank you very much.